morning friends. Today we are going to learn how to treat gastroenteritis, a very common disease. A lot of patients we are going to get in rainy season and a very frequent disease also in any season we are going to get in our OPD. So in the routine practice, it's vital for our OPD to efficiently treat these patients. So let's get started. We will see all the aspect of acute and chronic diarrhea one by one. So first we will go through the definition. This is Harrison based definition, and definition in two parts, that is the quantity and consistency of the stool. The quantity, so according to the definition, quantity must be more than 200 grams and consistency is unformed or liquid stool. Means if the patient is having more than 200 grams of stool which is formed or semi-solid, it is not diarrhea. If the stool is semi-solid or formed stool, we cannot say it is diarrhea. All right. Yeah, or the quantity is less than 200 grams per day, then also this is not diarrhea. So both the criteria must be fulfilled. The quantity must be more than 200 grams and the consistency must be unformed or liquid stool. Based on the duration, we can we can divide the diarrhea into three phases. One is acute, persistent, or chronic. Acute, when the diarrhea presents within 2 weeks. Persistent is from 2 weeks to 4 weeks, and chronic is more than 4 weeks. So we will see the causes of acute diarrhea. First we will see the acute diarrhea. So I have listed few common causes only, and in acute condition more than 90% cases are infectious. A patient presented to us with the diarrhea with a history of 3 or 4 days or 5 days, we assume that this is infectious diarrhea, right? And the second most common is iatrogenic, means patient is already taking some medication or patient is having constipation. He took some laxative but he don't know the dose, he overused it, and now he is having diarrhea. So this is also a very frequent cause of diarrhea. And some high risk group also there which are very vulnerable to the infection which causes acute diarrhea, like travelers who frequently travels to the endemic region where the diarrhea is endemic, so they get the diarrhea. Certain food consumptions, as we see the or raw rice or partially cooked rice, uncooked meat, these are the some certain foods which are definitely going to cause diarrhea. Uncooked meat, right? Immunodeficiency, we all know, if the immune status is, patient's immunity is very low, he is very prone for infection. Once he is prone for infection, easily get infected and get diarrhea. Nosocomial infections, these are hospital acquired infection, hospital acquired diarrhea. Patient or patient's attender who frequently exposed to the hospital environment. Hospital environment means a lot of pathogens. They are continuously exposed and they get. So once the patient has came to you in a OPD, now your target is how we are going to investigate the patient, right? So diet history, one of the most important part in the diarrhea, as patient is having allergic to some component of the food. So before giving to antibiotics or any therapy, we need to elicit all the diet history, like gluten sensitivity. Patient give history of diarrhea when he eats some chapati or wheat flour products. So but more than 90% cases, they all respond to broad spectrum antibiotic. Means, as we know that acute diarrhea in most of cases this is infectious, so we are going to give some antibiotic and they will respond well. But yes, that history we need to elicit, because patient may notice the diarrhea acutely but he is having diarrhea from previous years or few months also, right? For stool examination, we can order the stool examination if we are suspecting some unusual pathogen like fungus or any protozoal infections. Protozoal infections, we can have worm in the stool, we can have some kind of insect. Patient will tell that yes, I'm passing some bad insects in my stool. So you can elicit that, and for that you can examine the stool for the worms, right? Routine investigation, once you are given the treatment and patient within next 2 to 3 days, there is no within 2 to 3 days there is no response, so patient will came to your OPD again, and now you will order the some basic investigation which must include CBC, kidney function, and sodium potassium. Why CBC? For CBC, we are trying to see the state of hydration, that patient is dehydrated or not. In KFT, we will look for acute kidney injury, and for sodium potassium, we will look for electrolyte loss. That if patient is having diarrhea, there is a lot of electrolyte which are going to loss in our stool. So these three tests we are going to include in acute diarrhea, right? Acute diarrhea. Now the most important part is the treatment for when how you are going to deal with this patient in your OPD. For all the mild cases means when there is no signs of dehydration. So all the mild cases, theoretically, when you replace all the fluid and electrolytes, patient will start responding. But practically, this is not the case in every time. So practically, when we are practicing in our OPD, you need to give one antibiotic. Why antibiotics? Even when the patient came to you in your OPD and he didn't respond for 2 to 3 days. In next 2 to 3 days, if he didn't respond, then in the next visit, when patient revisit you, he will he might have some complaints with your treatment that your treatment is not good enough. He didn't respond. He may have some problems and blah blah blah. So for avoiding these kind of complaints, at the first contact, you add one antibiotic with symptomatic treatment so that patient, if there is some infection, the antibiotic will take care of it and the patient will respond. For acute diarrhea, you are going to give one antibiotic in each of the patient with diarrhea until unless there is very mild or there is no diarrhea. Patient feels diarrhea but there is no diarrhea. In that case, you can continue with ORS because we are not going to wait to make the diagnosis for persistent or chronic diarrhea. We can't wait 15 days, or a patient cannot wait for 15 days. See, once he didn't respond for treatment, or if you have given 2 to 3 times treatment and patient did not respond well, patient will find some other doctor. He will not come to you again. So you are not going to wait to make the diagnosis persistent or chronic. What's your target? To treat the patient at first contact. This is the target and this is how you can grow your OPD. So what is the treatment plan? What is going to our treatment plan? So what we have given so far, we have given one antibiotic. Now we have to give and we have to give symptomatic treatment also. So we are going antispasmodic for pain, spasmodics for pain. We are going to give one probiotics to restore the gut microbiota, and yes, oral fluid supplement. This is our whole treatment for acute diarrhea. This is our treatment plan. Now, this is sometime a query which most of the MBBS student thinks that we have a bacterial infection. We have a bacterial infection in our OPD, in our GIT, and now we are giving probiotics. What are the probiotics? Probiotics are the live strains of bacteria only. So why we are giving bacteria if we have already having bacteria over growth or bacterial infection? So probiotics are the good bacteria, and what kind of bacterial infection we are having in our intestine is bad bacteria. So we are giving good bacteria. What will they do? They will compete. They will compete with bad bacteria. So they will compete with bad bacteria, and they will enhance their dislodgement and improve the recovery. So this is the reason why we are giving the probiotics. And when we give antibiotics, bad bacteria will be killed. Once they are killed, we need to restore the intestinal microbiota, which will the good bacteria will help to restore the gut microbiota. So this is the reason why we are going to give probiotic in almost all cases of diarrhea. We have many other drugs for acute diarrhea, and one of them is anti-motility drugs, and the most frequent drug is loperamide. See, use of loperamide is we must use loperamide with very caution. Why? Because if patient is having diarrhea with blood, means if patient is having dysentery, and if we give loperamide in these patients, they are a very risk of perforation or obstruction. Why? Because loperamide decreases the intestinal motility significantly. So there is a smooth muscle, there can be severe smooth muscle spasm. Or if patient is having ulcerative colitis or Crohn's disease, there is a thinning of intestinal mucosa. There is thinning of intestinal mucosa and it will perforate when we have spasm in the smooth muscle. So they are very high risk of perforation. So when we have to give loperamide, when we having very severe diarrhea, means there is signs of dehydration. Signs of dehydration. Yeah, there is severe dehydration in patient is in altered sensorium. The frequency is 50 or 60 stools per day. They all are watery. So the loperamide will help to reduce the frequency very instantly. So in these cases, we can advise loperamide, but it not in all the cases. We have to rule out the dysentery. Once we have ruled out, we can think of loperamide in severe diarrhea. Resicadotil is another good drug, which is a anti-secretory drug. In secretory diarrhea, it works very well when you are having viral diarrhea. Like in COVID-19 infection in children, we have seen there is the manifestation is diarrhea. So where the resicadotil is a very good drug. But we usually use resicadotil in ROS non-responders only, or we are suspecting some secretory diarrhea like in viral infections. But in practice, if there is severe diarrhea, means patient may not have signs of dehydration. Patient is not having dehydration, but the stool frequency is 30 or 40 stools per day. In such cases, you can give resicadotil. Doxycycline is a very good drug when a patient is giving a very clear-cut history or very good history, when there is a very clear-cut history of rice watery stool. As we know, when you are seeing rice watery stool, we suspect cholera. Once we suspect cholera, drug of choice is doxycycline. So we can use doxycycline as an add-on therapy. There may not be a very clear history for rice watery stool, but the stool is completely watery and the frequency is very high, say more than 20 per day. So then in these cases, you can add doxycycline without making the diagnosis of cholera. As we already discussed, we have to treat patient in our first contact. So we will not wait for the response. We will try to treat at one sitting only. So here are the very important list for the MBBS and general practitioners. The what antibiotics we are giving, we are talking about that we have to give antibiotic, but which antibiotic, which antibiotics? So we have many antibiotics in the market in combinations. Few very common available are Norflox plus tinazole is Nortized, Oflox plus onidazole is O2, Ciprox plus ciprofloxacin plus tinidazole is ciproxtized, and there is Doxep-O also, ciprodoxin plus ofloxacin. When we give a combination of antibiotic in diarrhea patient, in most of the cases, we must ensure that one of antibiotic must cover the anaerobes also. As we know, in intestine we have two kind of bacteria. One is gram negative, and second is anaerobe. So we having these kind of bacteria. So one antibiotic we are giving must include anaerobes also. So most of the antibiotics here is the tenalazole, onidazole, or metronidazole. These are going to cover anaerobes very well. For add-on antibiotics, we have doxycycline. It is available in the market as the name of Doxy or Doxy LV 100 mg, and we are going as a base a day frequency. And for probiotics, we have Sporlac plus, Darolac, Lactovate, Enterogermna. These are the few very common brand names, and we are going to give base a day or trace a day, means thrice a day or twice a day. For antispasmodic, we have painkillers in combination. Meflospar is a very common drug we use, and many of the patients use very frequently. And this is dotaverine plus mefenamic acid. Zerodol or GC spas. This is dotaverine plus aceclofenac. These are the very good some of the very good painkiller with combinations. Dotaverine is antispasmodic, which is common in all, that will take care of spasm. For anti-motility, as we have discussed, we have loperamide, a 1 or 2 milligram in frequency, and the brand name we have Lomofen, Imodium, or Ropo. Anti-secretory, we have Resicadotil, available as Ridotil or Residual in the market in 100 grams of capsule, and the frequency is bis or tris, means twice or thrice a day. Now we came to the chronic diarrhea, how we are going to treat chronic diarrhea. Once you make the diagnosis of chronic diarrhea, means diarrhea more than 4 weeks, the cause is very different. There is more than 90% cases are non-infectious. So now I have listed a few very common causes of common diarrhea. They are very few causes. If you go through the Harrison, there is a good chart. There is a good list of detailed causes. They classify the causes according to the system and etiology. So if you want to read in details, please go through that table. Most common causes what we see in our clinical practice is overuse of laxative, as we have already seen. Patient may not aware of the dose and he misuse or overuse the laxative, and now beside the constipation he is starting having diarrhea. Irritable bowel syndrome, we have a good lecture with irritable bowel syndrome, and we have seen that these patients are, when we having patient IBS-D, means diarrhea prominent IBS, patient will present with diarrhea. Malabsorption syndrome, patient is always diarrheic if he having fatty stool. In HIV patient, in hypothyroidism, cholecystectomy and idiopathic. Cholecystectomy, we don't have gallbladder. Once we don't have gallbladder, the function is lost. So whenever patient takes some fatty meal, the patient start having loose stools. And idiopathic means we don't know the cause. Very. Now the most important part, the investigation. As we having, once we have diagnosed the patient as chronic diarrhea more than 4 weeks, it is going to difficult to find out the exact cause, because our target is to find out the cause. If we want to treat the, if we are willing to treat the chronic diarrhea, we must find the exact cause. Once we find the cause, we can think of treating the diarrhea. And getting exact cause is sometimes very difficult and it requires extensive evaluation. And now we will start with history. In a history, we will include the drug history, that what kind of drug, if patient is taking all the drugs, what kind of drugs he is taking, stool characteristic, if there is any aggravating or relieving factors, there is associated with meal, there is some any associated features with diarrhea, we will include all of them within our history. Family history, yes, that is very important in chronic diarrhea, because if patient is having Crohn's disease or ulcerative colitis, or patient may have diabetes, these all having going to have some kind of family history. Or in malignancy also, patient may have some family history. So for that all, we need to get family history. Extra intestinal features may have goiter, may have lump, may have joint pain. So these all things we are going to elicit in our history, that will help us to guide the to get the exact cause, and we will investigate the patient accordingly. When we examine the patient physical finding, we might get some lump or mass anywhere in the body. That most common is abdominal. In cardiac auscultation, we have murmurs, we have lymph nodes on palpation, or any edema over the face or fetal edema. So according to the symptoms, our history and our physical findings, we will. Now, these are the four simple steps, four mnemonics for the clue to the diagnosis. We are talking about chronic diarrhea, means more than 4 weeks, diarrhea of more than 4 weeks. If patient is having diarrhea with blood, we will ask the patient to go for the colonoscopy with biopsy, that will diagnose ulcerative colitis or Crohn's disease or any lower GI malignancy or any pathology which is involving lower GI. So that will be easily diagnosed with colonoscopy if patient is having blood. If patient is having diarrhea and the stool patient is passing containing fat or undigested food particles, so we will order upper GI endoscopy with biopsy, that will diagnose malabsorption syndrome. Any celiac disease if patient is having, any other kind of sensitivity or any pathology, upper GI mass is can be there, so we will diagnose all the cases with upper GI. If patient is having diarrhea and which is related to meal, means whenever patient take meal, patient get urge to pass the stool, means our diagnosis will point towards the irritable bowel syndrome. We have discussed in details in our previous lectures, so we will not discuss here. If patient is having diarrhea but there is no associated or and no specific feature with associated with diarrhea, so that can maybe a functional diarrhea. So these are the four easy point. Now once we came to the treatment part, treatment is can be curative, can be suppressive, or can be empirical. Empirical, if we find some malignancy or incurative disease where we can't eliminate the cause, we will go for the empirical treatment. Suppressive means we cannot treat the cause, but we can suppress or we can control the diarrhea, we will go suppressive. Curative, if we find the treatable cause, we find treatable cause, we can cure the diarrhea. Chronic diarrhea is sometimes very difficult to treat, so we have to keep these all three things in our mind. If we are willing to treat the patient, if we are willing to get a patient complete recovery, we need to find the underlying cause, and treating the underlying cause is vital for the recovery, right? Symptomatic and supportive treatment is always given along with the specific treatment. Symptomatic means if patient is having pain, we have to give antispasmodics. If patient is having probiotics, must be given. Oral supplement must be given. These all three will be given along with the specific treatment, right? So thank you so much. Diarrhea with blood means dysentery. We will cover this in our next lecture because the differential for dysentery is very different from the watery diarrhea. So we will discuss these points in our lecture, in our different lecture. Thank you so much. Keep